Yeah, so this is part of quite a long-standing piece of work. It goes back over 20 years. So estrogens are essentially the oldest cancer therapy, non-surgical cancer therapy, dating back to the 1940s. But oral estrogens give you high risks of thromboembolic problems. So the program was initiated by a chap called Paul Abel, who sadly died a couple of years ago now. And the hypothesis was by using transdermal estrogen, you could suppress testosterone without the problems of thromboembolism, which is why HRT patches are used rather than oral estrogens in postmenopausal women. And he was able to show that you need to use more than one patch at a time, typically starting with 3 and dropping to 2 for the standard preparations. But once you've done that, you can suppress testosterone to castrate levels very effectively. So the program then went on to show that quality of life was better than with ADT, standard ADT. So you get better preservation of sexual function, fewer hot flushes, you get bone density preservation much better, you get lower cardiovascular risk than with standard ADT. The only thing that is worse is gynecomastia, as you might expect. But gynecomastia happens as well with standard ADT. So all of that work has already been published, and then there was a phase III trial, non-inferiority trial called PATCH, that had been running for quite a few years alongside another trial called STAMPEDE, which I lead. And then STAMPEDE was essentially make it very hard for PATCH to recruit because they're recruiting the same patients. So we then merged PATCH into STAMPEDE as an additional arm. And so that's in 2 parts, non-inferiority in M0 and non-inferiority in M1. And we showed the non-inferiority data for the M0 patients at ESMO, and it is non-inferior. What we were aiming to show with this thing was that for the metastatic patients, you could combine effectively estrogen patches with oral ARPI therapies, so abiraterone, enzalutamide, and so on. And clearly we don't have a fully powered comparison of ADT, ARPI versus patches ARPI. So it's, if you like, a phase II trial embedded within a much bigger phase III trial. So the endpoint we chose was undetectable PSA at 6 months, and we compared the rates, which we defined as less than 0.2. We compared the rates on the 2 arms, and essentially they're identical. There was nothing to suggest that ARPIs were less effective if combined with estrogen patches, which is what we expected. I mean, there's lots of caveats, it's limited numbers, it's a phase II trial and so on, but from first principles you'd predict it should be fine. Also, there were no unexpected adverse events observed with the estrogen ARPI combinations. So our conclusion is that this is a reasonable option, or will be, subject to the non-inferiority outcome, which we'll present probably this meeting next year, I'm suspecting. But in terms of the safety of the combination, it's fine. We know it's safe in M0. We know it's effective in M0 in terms of the non-inferiority. And the other thing that's very important about this is that in large chunks of the world, men are self-paying for their ADT. That includes uninsured patients in America, of course. And basically, estrogen patches cost pennies. They're much, much cheaper than injectables. So apart from the quality of life gains, there's potential cost gains as well. And of course, that applies to the healthcare system as a whole. So one of the things that we're doing with these data is, so my own hospital, for example, has already put this on the formulary for newly diagnosed prostate cancer patients, so I can prescribe it. But more importantly, we're going through an orphan drug licensing process with the Medicine and Healthcare Regulatory Agency, the MHRA, in the UK, to have it formally adopted as a drug. And we have all the necessary elements for that package that will, I'm sure, go through in the next few months.